This is a 26-year-old male soccer player who has had chronic posterior instability. The shaver is up against the posterior cruciate ligament in the back, which has been torn, and the anterior cruciate ligament is seen crossing over the front of it. The first thing that needs to be done is to assess how the instability affects the patient. This particular patient was having giving way episodes of the knee, and it was decided to reconstruct the PCL ligament. The shaver is first used to debride the old posterior cruciate ligament stump. This allows us to see where the new ligament will be placed, as well as placing the ligament in an anatomic position. The shaver is used to deepen the footprint back to the wall of the femur until we can see into the posterior aspect of the knee. Once this is done, we are going to use an electrocautery device to mark out where we would like our drill hole to be placed. Typically this is in the anterior aspect of the old posterior cruciate ligament footprint, about 8 millimeters off of the articular cartilage margin. Once this is done, a posterior medial portal is established over a spinal needle. The shaver is now being placed into the posterior medial compartment. We now need to remove the stump of the posterior cruciate ligament attachment off of the back of the tibia. This is done with a combination of a shaver as well as curettes. Here we have an angled curette, and this is being used to take off the fibers of the posterior cruciate ligament, which can extend 1 centimeter below the actual tibial surface. Once all of the tissue has been removed and the tissue debrided, then our posterior cruciate ligament guides can be inserted. This is another view of the back of the tibia with the camera now placed in the front. You can now see that the back of the tibia has been nicely exposed, and now our guide is being placed up onto this surface. Once the guide has been placed, we then make a drill hole from the front of the knee out the back. Care is taken with this step to avoid the nerves and arteries in the back of the knee. The guide itself helps protect against over-penetration of the drill bit. Once the drill bit is in place, it is then over-reamed with a reamer to the appropriate size tunnel, as you can see here. This can be a slow step to ensure that, again, over-penetration of the cortex is not violated. Once the back tunnel is made, then a guide is placed back into the footprint of the posterior cruciate ligament in the front of the knee. Another guide pin is then placed from outside in under direct visualization. Likewise, once the drill bit is identified, this is likewise over-reamed with a reamer to the appropriate tunnel size. In the meantime, an Achilles tendon allograft has been prepared off a side table to fit these tunnels. Usually a size 10 graft suffices. Once the tunnels are made, the tunnels are smoothed of rough edges by way of a Gore-Tex graft. Here we are passing the graft through both tunnels under direct visualization. Once this step is complete, the actual graft can then likewise be attached to the graft master and pass through the tunnels. Here you can see the suture leading the actual reconstructed ligament through the tunnels as it's being passed. Once the bony blocks have been pulled into the tunnels, these are then secured utilizing bioabsorbable screws.